to admit my gaydar was going off when I came in the room. I was like, whoop, whoop, whoop. So I'm the Pride Health Coordinator, and I have only been so since January, and I'm really excited to be in the position I'm in. And just for anyone here who doesn't know what Pride Health is a program of the Capital District Health Authority in partnership with the IWK Health Center. Essentially, it exists to help address health inequities within the healthcare system and increase access to healthcare for the GBLTI communities within this District Health Authority. I think it's a really exciting and innovative program. It's one of a very small handful of programs across the country that specifically are designed within the system to address these issues. And I think that we're really lucky to have that and have that support here in Nova Scotia in this health authority. Pride Health takes two approaches. One, we have kind of two streams. We have one stream that actually we have a nurse who goes out into the community, into safe spaces where GBLTI people are to provide frontline healthcare services, which is really important. It means people don't have to go into institutions that they don't feel safe in, that they don't feel they have access to, that they don't see themselves reflected in, and that they just aren't going to, which we know. The other stream, which is more the stuff that I do, is really taking a systemic approach to that in consultation with the community through health promotion, creating supportive environments, education, awareness, and being part of policy development. And I think it's a really exciting place to be. My background is 15 years working in the HIV/AIDS community, and I have seen and witnessed the effects of homophobia, transphobia, and heterosexism on health outcomes for many years, as well as in my own personal life. I'm a queer woman, and I use the term queer with pride. I use the term queer because it's an umbrella term for those who are not heterosexual or gender binary. I don't call myself a bisexual because I don't believe there's just men and women in the world. And I'm not just attracted to men and women. I'm attracted to a whole continuum, and I'm proud of that. I know that there's a lot of history around the term queer, and for some people it's a very uncomfortable term. And I just wanted to address that as well, because it was a derogatory term, a slur, as were many of the terms that were used for people in the GBLTI community. And today it's used by those who don't identify with traditional gender identities or with traditional sexual identities. And really, it's because of people who were willing to stand up and say who they are and be proud of who they are, and who were willing to be beaten and institutionalized and jailed so that I can stand here today. And so I owe that huge debt. And it also means I have the freedom to have a sexuality that has a fluidity and be proud of that. So I'm really happy to be here today, and I'm happy to be talking about this. It's also not just a fad term. I've been calling myself queer for, I don't know, 15, 20 years, and it hasn't gone away yet. And I don't have to choose. I can just be who I am. So I just wanted to kind of preface that in terms of who I am. I wanted to talk a little bit about what we know and about statistics in the community, in the GBLTI community. I think one of the things that was spoken to earlier was that the environment has a huge impact in health and health outcomes, and social inclusion or exclusion is about our environment, and I wanted to talk about that. Stats are always a challenging thing, and in the GBLTI community, they're incredibly challenging. So let's talk about what we do know. We know that in the GBLTI community, we have increased rates of suicide, at least 3 times in the GBLTI community, and 14 times among gay men. We have higher smoking rates, 50% higher for gay men, 100% higher for lesbians. We have higher rates of depression, 3 to 5 times higher than in heterosexuals. Higher rates of violence. 70% of GBLTI people have been verbally abused, and 25%, and I would guess that actually is higher, have been physically abused. Higher rates of alcohol abuse and addiction issues. An estimated 30% of GBLTI adults have problems with alcohol. Higher rates of sexually transmitted infections. Continued increasing rates of HIV among gay men and youth. Higher rates of hepatitis A and B. Increased anal cancers. Higher levels of obesity in lesbians, higher levels of eating disorders in gay men, higher rates of homelessness and street involvement in our GBLTI youth, and higher rates of sexual abuse in our histories. And I think one of the most prevalent stats that we have is we have higher rates of unmet healthcare needs, 21.8% compared to heterosexuals who have 12.7%. And I think that's really key because we need to unpack what that means. What is an unmet healthcare need? And it can mean any number of things. It can mean people aren't going. So it's there. Why aren't people going? They're not going because they don't feel safe, because they don't feel it's a place for them, because they don't feel like they can actually talk about who they are, because the healthcare provider doesn't know what to ask or how to ask it, and the healthcare risks aren't even known among the community. And if you don't feel safe to tell people who you are, then how can that possibly be addressed? These stats come from a fellow named Banks, and he did a literature review, probably it's the best, the most comprehensive literature review that was done in Canada, and it's called the Literature Review on the Human Impact of Homophobia in Canada, and it's from 2003. So those are the most recent stats that we have, and they're limited, and I'm going to talk about their limitations in a minute. But one of the really prevalent things that he said is the cost of social exclusion among the GBLTI communities equals 5,500 premature deaths in Canada and approximately 8 billion costs annually. That's a huge amount. For all you people who like to crunch numbers, that's massive. And I think that's really important. What I want to talk about is stats this is what we know, but we need to unpack that because where we get those stats, we don't get those stats from mainstream health promotion research, policy, or practice. We know that the populations that are marginalized by gender identity and sexual orientation are left out of these exercises. They don't exist. Those stats are not collected anywhere. Those questions aren't being asked. There's nowhere where we can go and say, oh, let's mine the data. The data doesn't exist. I'm going to tell you where those numbers came from in a minute. We know that research that gives up-to-date hard data about GBLTI communities and health doesn't exist because it's not been done. And the GBLTI community has largely not been recognized as an identifiable population within the healthcare system. So essentially, as a community, we've been ignored. And that's not even taking into account the cross-section of race that was spoken about earlier. Those stats are just like way out of our realm. They're not even on the radar. Neither are our stats. So we know, and the stats that I just talked about, we know that the health and well-being research of the GBLTI communities have, for the most part, been identified and taken up by community-based initiatives. We've done it ourselves because we've seen that need. And in essence, the GBLTI communities we've defined our own health and well-being issues, needs and concerns, including examining the structural sources of health inequities that the social determinants of health framework often miss for our communities. So we've really had to look at the structural systemic reasons why this occurs and why these numbers actually exist. As you all know, working in healthcare, it's all about evidence-based. We all need data to move forward, to create programs, to say, we need this is what we need. And if that data isn't even being collected, what do? And that's about policy, and that's about approach. We know that the outcomes of heterosexism and homophobia equal violence, persistent threats of violence, discrimination, social marginalization, isolation, social invisibility, self-denial, and guilt. And ultimately, all of this results in people not accessing the healthcare that they need to address these issues, let alone any other healthcare issues that they may have. I think it's amazing that we're here today to talk about these things and to have a forum to further explore these things. And one thing I would encourage everybody is to put on your research hat. And when you have your research hat on, remember who you're missing in the research and really unpack what that means. Thank you.